Attendee Hub. Hang on just a second, I'll get this started. My apologies. There we go. Good morning and welcome to our conference session. What's my mutation? Understanding the risk for low, moderate risk patients. Thank you for joining us. My name is Julie Powers and I'm the Senior Director of Patient Advocacy and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and patients, families, and caregivers who are supporting our conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or comment, type your question into the box and press enter. Please do not include private health information about the patient in your question. Our presenter cannot answer specific questions related to your diagnosis or your treatment. We will try to answer all questions during the webinar. However, if we're unable to get to your question, please feel free to send it to help, HELP, at aamds.org. Today's speaker is Dr. Tiffany Tanaka. Dr. Tanaka is a board-certified hematologist specializing in the diagnosis and treatment of blood cancers and blood disorders with an emphasis on myeloid malignancies at UC San Diego Health. Dr. Tanaka is a translational researcher who focuses on the development of early phase trials that offer new cancer treatments for patients. Her research work includes the study of epigenetic and genetic biomarkers in myelodysplastic syndromes, bone marrow disorders in which the bone marrow does not produce enough healthy blood cells. Dr. Tanaka is a member of the American Society of Hematology, where she has presented her research work. Dr. Tanaka completed a fellowship in hematology and oncology at UC San Diego School of Medicine, where she also completed a residency in internal medicine. She earned her medical degree from John A. Burns School of Medicine at the University of Hawaii. She is board certified in internal medicine and hematology. Welcome, Dr. Tanaka. Thank you for being with us.
Thank you so much, Julie, for that kind introduction. I'll go ahead and share my screen now with the PowerPoint. And it's so good to be back with the AAMDS International Foundation. I really appreciate this invitation. Today I'll be talking about lower risk myelodysplastic syndromes, or low moderate risk. And today we'll be focusing on how to diagnose this disorder and some of the different treatment options and how we go about picking the best treatment. So first we'll talk about diagnosis. And to formally diagnose myelodysplastic syndromes, first a bone marrow biopsy is needed. The reason why a bone marrow biopsy is needed is because the bone marrow is where the blood cells originate. And so the blood stem and progenitor cells, or all the cells that are at its most primitive form, will one day mature and become these fully differentiated or fully mature blood cells. And that's what we see in the circulation. So you've got a blood stem cell or early stem cell that matures in the bone marrow to become red blood cells, different types of white blood cells, and lastly, platelets. All of these blood cells can be affected in myelodysplastic syndromes. And so In order to do the bone marrow biopsy, it is a procedure that can be done as an outpatient, fortunately. Most patients are able to do okay with local anesthetic, but there's other options if need be. And it's taken from the back hip traditionally, where the biopsy enters from the skin and then through the bone. And then we take samples of both the bone marrow aspirate as well as a solid piece of the bone. And that allows us to really look at the architecture within the bone marrow and look at all the different blood cells and see if there are derangements consistent with MDS. The word MDS stands for myelodysplastic syndromes. That dysplastic refers to the abnormalities we see in the actual shapes of the blood cells. So before we jump right into a bone marrow biopsy, often patients are referred to the clinic for low blood cell counts or abnormal blood counts. And the first job of the hematologist is to make sure there aren't other explanations for the low blood counts. A lot of times there might be benign causes. When I say benign, I don't mean it's not harmful, but benign in the sense that it's not cancerous or not malignant. And so what I've got here is an assortment of different disorders that can lead to low blood counts, chronic viral issues like HIV and hepatitis, a host of medications that can actually affect affect the bone marrow's ability to produce blood cells, organ damage outside of the bone marrow, such as the liver, hepatic, or the kidney, renal, and then vitamin mineral deficiencies, as well as heavy alcohol use can do it. So once those things have been ruled against or don't seem to be the main driver for lowering the blood counts, that's when a discussion begins about potential non-benign or what I call clonal causes of a low blood counts. And so that includes MDS. There can also be other disorders that seem similar or even mimic MDS that are also bone marrow in origin. And that's what we often refer to as overlap disorders. So often when we take our boards, when we do our training, patients on the books look straightforward, they fit one box cleanly, but in reality, a lot of patients, they bridge multiple diagnoses. And so that's where the bone marrow biopsy, as well as newer tools such as genetic testing, can really help us figure out what is the precise diagnosis, if possible. So once we've arrived at that actual diagnosis, we've decided to do the bone marrow biopsy. The bone marrow confirms our suspicions of having MDS. Then we talk the patient through how is that going to affect their everyday life and then the long term. So in everyday life, most commonly MDS presents with low blood counts, and consequence of that includes an increased risk of bleeding due to having low platelets, an increased risk of infection due to having a low white blood cell count, particularly a low neutrophil count, which is responsible for protecting patients against infections, bacterial most commonly. And then lastly, an increased risk of symptoms due to anemia. So anemia is when the red blood cells are lower, and those are your oxygen carriers. And so symptoms of anemia can lead to feeling more fatigued and more short of breath, and that limits the activity level. And then what's very difficult to anticipate is the risk of leukemia. There are tools to do that. And in a broad sense, we estimate about 1/3 of patients with MDS will one day develop leukemia or acute myeloid leukemia, AML for short. So I talk my patients through those potential consequences, if not already apparent. And as mentioned with the bone marrow biopsy, we're looking for dysplasia. These are some hallmarks of dysplasia or changes in the blood cell shape that the pathologist diagnoses. And so some of these are pictured here, such as abnormal white blood cell deformities of the nucleus, and that's the pseudopelgar anomaly. Some abnormalities of the red blood cells with ring sideroblasts. This is a megakaryocyte or a platelet precursor where the nucleus is abnormal as well. And these are myeloblasts or the leukemia cells that might be present at a lower level in MDS. So the changes in the cell shape is the gold standard for diagnosing MDS that has to be present. What really helps support a diagnosis is having abnormalities in chromosomes that are known to be affected in MDS, and about 50% of patients will have a chromosome abnormality. And then lastly, DNA mutations are found in the majority of patients with MDS. This isn't available at every center, but most centers have a way to send for this. These aren't DNA mutations that patients are born with. They're not inherited from one generation to the next. That's the most common concern my patients often have, is that they've either received it from their parents and therefore have passed it on to their children. So these are mutations that are obtained or acquired later in life. And so having one or more mutation in a gene known to be associated with MDS is very helpful to support a diagnosis. So these are the tools that we use to confirm the diagnosis. Once we've done that, the pathologist then categorizes the MDS into one of these different subtypes based on what the pathologist sees in the bone marrow. These are different subtypes of great detail that the World Health Organization has classified. They do this every several years. They update their classification system. So this is the latest that was reported. This is not so much something I lean on to tell patients how I expect their prognosis to be, but this is more specifically something that the pathologist does. But that being said, there are certain subtypes that can drive which treatments we use, and that's why I bring it up now. I'm going to return to this particular subtype, isolated del5q. There's a specific drug that works well for that condition. And then there's also this MDS with ring sideroblasts, or MDSRS. There's a recent drug approved just for this type. So that's why I bring up these different subtypes. What all of these subtypes have in common, though, is the requirement for dysplasia greater than 10% of all the bone marrow cells, and less than 20% blasts or leukemia cells. If patients have 20% or more blasts, that they then cross that unfortunate threshold to acute myeloid leukemia. So that 20% is kind of a black and white boundary we use for pathology. So once we have confirmed the diagnosis of MDS, a common question and a very appropriate question next is, what is my MDS stage? So unlike a lot of solid tumors like breast cancer, colon cancer, MDS and a lot of blood disorders, we don't use the same stage 1 through 4 system. And the reason why there's a different scoring system is because blood cancers, unlike solid cancers, the blood pervades all throughout the body, as the bone marrow does too. And so with solid tumors, we often use the degree of how far the solid tumor has spread, beyond the colon to the lymph nodes to further in distance. Or in blood cancers, we can't use that same physical spread. And so I'm about to show you the different things we use for MDS. This is based on a study done internationally on 7,000 patients, where they came up with different risk factors to know how risky it makes a patient's prognosis. And so this was done and published in 2012. These are the 5 factors that were derived from those 7,000 patients. Hemoglobin, or the red blood cell number. Secondly, the absolute neutrophil count, which is a type of white blood cell important for bacterial infection protection. The third is the platelet count. That's a type of clotting cell, or cell that achieves hemostasis when you get a cut. And then fourth, bone marrow blasts, or percentage of leukemia cells. And then lastly, fifth, the chromosome abnormalities. Again, not something inherited, something that is picked up with age. And what we do is we quantify how abnormal each of these 5 are, put them into categories, tally up a score, and that therefore tells us if the patient is, which category they're in. There's 5 different categories spanning very low, low, intermediate, high, and very high risk. So there's actually a really handy calculator on the MDS Foundation. If you just Google IPSS-R, you'll find this calculator, and you can actually plug in the score. And this is something that hematologists will use in the clinic. So I've got an example patient. Margie's a 78-year-old woman that came to the clinic, and she had a hemoglobin of 8.2, which is bad, much below the normal for most. About 11 is considered normal for women. Her neutrophil count, fortunately, was normal. Her platelet count was also in a very good range, 240. Normal range by most labs is 150 to 400. We went ahead and did a bone marrow biopsy, and fortunately, the amount of bone marrow blasts or leukemia cells was low. And then lastly, her chromosomes were normal, so also a very good sign. So using the IPSSR calculator, we can then take these scores, plug it in for what Margie had, and you'll see that she didn't get very many points, only a total of 2 points, putting her in the category or stage of low risk. So the lower the score, the better. And happy to say that Margie's considered to have low risk disease. So what does that mean? Very low, low, intermediate, high, very high. This actually correlates with the actual survival based on the IPSSR 7,000 patient study. So this is data from the actual IPSSR. I color coded it here where very low and low are in blue and green respectively. And what this graph represents is the survival of these patients in each category or each stage. So on the vertical or y-axis is the percentage of patients. And then on the horizontal or x-axis is the survival in years. So you can see that blue or very low risk, there's a higher percentage of patients living for several years. So if you go to the middle of that, 50%, that goes all the way out to 8.8 years precisely. So what that means is half of patients at 8.8 years with very low risk disease will still be alive. Now contrast that with a patient with very high risk disease. That's represented by the red line here. If you go to that 50% bar again and draw it out, there 50% of patients will be alive, but only at about 0.8 years if you draw a vertical line down here. So we really rely on this IPSSR score to determine what the survival is. Lastly, this IPSSR score also predicts the risk of a patient moving from MDS to AML in their lifetime. Very similar to survival, where you see very low compared to very high. It correlates with their risk of leukemia transformation. So again, a really helpful tool to use in the clinic. Get the bone marrow biopsy, get the blood counts, tally up the IPSSR score, put the patient into a stage to predict how long we think they might survive. I'm just going to briefly mention genetic mutations. What you might notice is in this IPSSR score, there's no mention of DNA mutations. The reason why is the amount of mutations out there in MDS is high, and even more high is the amount of combinations of more than one MDS mutation. So there were 3 landmark studies, much more than that, but these were some studies that came out around the same time, almost 10 years ago now. And they found that there were just a lot of different MDS mutations and mutation combinations. We know that these mutations, some of them do correlate with survival, but it's been difficult to integrate these with the IPSSR. And so I bring this up because one day we think that there will be a more formal incorporation using these mutations, but not done so yet in the IPSSR. Right now, a lot of physicians use what's called the NCCN guidelines, or the National Comprehensive Cancer Network. Each cancer type has a panel of experts that discusses the latest data and incorporates it into these guidelines. And right now, the way that the gene mutations are used is this long list. You can see here in column 1 are the different types of mutations, exactly where they occur in the gene, how common these occur or the incidence, and then what we think it means clinically. And as you can see here, for some of them, it's simply saying associated with poor prognosis or more frequent in leukemia, but not yet more quantifiable than that. And so we're looking forward to figuring out how to use this in a practical way. Um, and so we know that for sure gene mutations can really support that MDS is present, and they can also predict survival. And we're looking for ways to use that more routinely and more in a more quantifiable way. Okay, so we've talked about diagnosis, we've talked about prognosis or stage, and now I'm going to spend the remainder of the time talking about what are the different treatment options for lower risk MDS. So when I speak to patients in clinic, I really like this figure that Dr. Platzbecker put out because I think it captures just the general attitude for lower risk MDS versus higher risk MDS. So with lower risk MDS, as mentioned earlier, we predict that patients will fortunately be with us for several years. And so the emphasis tends to be a little bit more on quality of life, how to improve the cytopenias or low blood counts to lead to less transfusions and less iron overload, which can be damaging to the organs, and really improve that quality of life and potentially improve survival and delay the disease from getting worse. With lower risk MDS, the goal is not so much cure because we know most of the patients, because the MDS is not limiting their lifetime by much, they are more likely to decease of other reasons. And so the emphasis is more on preventing complications and improving the quality of life. Now, with high risk MDS, that's sort of flipped on its head. High risk MDS, we know that the actual diagnosis of MDS is going to be what potentially takes the patient away, leads to their death. And so the emphasis is more about cure, survival, disease modifying treatment with chemotherapy, and that sort of thing. So that's just the general approach to set the stage. Now, in this slide, I've got just all the different treatment options as a list. We'll go into each one in more detail, but what I wanted to present here is that fortunately, as the years have gone by, we've got more treatment or more tools at our fingertips. And what's not wrong for a lot of patients is simply close monitoring. The more intervention that's done, potentially there are side effects to those. And so if the side effects exceed the actual symptoms of the disease, monitoring is not a bad choice, meaning if the patient is not affected or just very mildly affected by their low blood counts, monitoring might be the best way to go. And then a step beyond that is what we generally refer to as supportive treatment, which are treatments that don't necessarily modify the disease. They don't change the way that the MDS behaves, but we're simply supporting or trying to augment how the patient's affected by things that are minimally invasive, such as a transfusion. And from there, there are treatments that are a little bit more invasive, but not as much compared to the typical options for higher risk MDS. So I'll go into each of these. Before I do so, though, I just wanted to take you through a quick sort of step-by-step approach. Most commonly, such as with our example patient, the 78-year-old Margie who came with a low hemoglobin or anemia. Anemia is possibly the most common type of low risk MDS that needs attention. And so when a patient comes with anemia only, this is my general approach. If the anemia is mild and not requiring transfusion, not leading to side effects or symptoms, then that's someone that I would just observe. I typically, depending on how anemic the patient is, how symptomatic they are, I might tell them to do blood counts on a monthly basis, sometimes less than that. If the anemia is becoming more moderate or severe, if it's moderate, but we're not right at the need for intervention, then I might say do the blood counts more often, every 1 to 2 weeks. But if it's moderate, severe, causing symptoms, then we might have to take action right away. And so the first step is to look for a particular chromosome change. And I mentioned this earlier in the talk when I gave that long list of MDS subtypes. There's a type called deletion 5q, where part of chromosome 5 is missing. And the reason why we care about this is there's actually a drug that has very targeted effects on this type of chromosome change. And that drug is called lenalidomide. So if a patient's got that one chromosome abnormality, this is the drug of choice. Now, if a patient does not have that deletion 5q abnormality, then the next step that is proposed is to check the serum erythropoietin level, EPO for short. Erythropoietin is made by the kidneys. It's a normal hormone that tells your bone marrow to make more red blood cells. We know that if the lower the EPO level is, the higher the chances that the patient will benefit from getting more EPO, or the acronym here is ESA, erythropoiesis stimulating agent. So if you've got a lower EPO level in your body, you have a higher chance of doing well if you get more EPO in the form of a drug. If you've got a high EPO level, then we know giving more probably will not help. And so it's proposed to try this drug called luspatercept, which is a recently approved drug. Lastly, if you do have a low EPO level, you get more EPO as a drug, but it does not help, then again, you can go to luspatercept. So I'll go into each of these drugs now individually. So first drugs or family of drugs to talk about is these erythropoiesis stimulating agents, ESA for short. And so there's a lot of different formulations now out there, which is nice. Epoetin alpha is the one that's shorter acting, and it's dosed every week traditionally. Darbepoetin is the longer acting, and that's traditionally dosed every 2 weeks. So some of these brand names are Procrit, Epogen, Retacrit, Aranesp. A lot of times different universities or different medical centers are contracted with different brands. And so that's why you might hear one physician prescribing one or over the other. It just comes down to the formulary and what's available right away. So as mentioned, EPO is normally made by the kidneys, but in MDS, we know that greater amounts of EPO are needed because the bone marrow is not properly maturing the red blood cells enough. And so we need to give more EPO to do it adequately. So EPO is given as an injection under the skin or subcutaneous, and then as mentioned, every 1 to 2 weeks. Sometimes patients need that more, sometimes they need it less. Often we are doing the blood counts every week with the injections, and that's how we can determine if a dose is needed more or less and adjust from there. The actual handout that comes with the drug has very precise dosing recommendations, telling physicians how to change that dose. And so it's really important that patients actually get their blood checked every week to make sure we're not overshooting or undershooting. Now, side effects with this drug generally have been rare in my practice. Nevertheless, patients infrequently may have headaches, some have joint pains, and this is very rare, but blood pressure might become more elevated. And so what we do is we measure the blood pressure before the drug is given. This is quite rare, but thrombosis is a warning on the drug. And so if patients have risk factors for developing thrombosis or blood clot, then this drug might be considered not to be given. It just depends on what those risk factors are going into it. I included this figure or this graph from a recent study done on looking at a modified criteria for measuring which patients will benefit from EPO. And so what they found is the lower the EPO level, not surprisingly, the more likely someone will respond. And they actually found that patients starting with the EPO level below 200 had an even higher chance. And so getting that EPO level checked before you give it is really helpful just to set expectations and know the patient's more or less likely to respond. What this graph is showing on the horizontal axis is the probability of becoming transfusion free or no longer needing transfusion. And then on the horizontal axis is the time in days. So basically, the more time that has gone by, the less likely a transfusion is needed. And so on top is the patients who had a lower EPO level and a lower transfusion amount. they did the best, where as time went on, they became transfusion free and they stayed there for many days. So on the horizontal, again, that's in days, 364 here. So this is the 1 year mark. The majority of patients were not needing transfusion. Whereas the patients who received placebo, that's in this dashed arm here, not surprisingly, just in a matter of months, the majority of them were needing transfusion. And then in the solid bar in the middle, those are the patients that did not respond. And so they did do better than placebo, but those are the patients with the higher amount of EPO in their body to begin with. Okay, so we talked about ESA. Next, we'll talk about lenalidomide. Really long name. Lenalidomide is the drug that is known to be most effective for patients with this deletion 5q abnormality. So that's shown here. This is chromosome 5. So you've got a pair of chromosomes for each chromosome. And what's missing is part of 5q. And so that's something that the pathologist helps the hematologist with, is they literally take the actively dividing cells or actively actively replicating cells, and they investigate the chromosomes and can tell us at which ones have missing or duplicated areas. So it's important that lenalidomide be used for patients with only deletion 5q missing. If a patient has 5q missing but other chromosome abnormalities on top of that, we know lenalidomide will not work well. So point of emphasis is only deletion 5q is there. Lenalidomide is a pill. So that's what's really nice about it. Unlike EPO, patients do not have to come in routinely. They can take the pill at home. That being said, I do require that patients get their blood drawn weekly once they start this pill. And the reason why is the side effects. Sometimes patients can have lower blood counts. And also we want to see if patients are moving in the right direction on this pill. And so a really wonderful statistic is this one. 70% of patients with only deletion 5q will one day no longer require transfusions on lenalidomide. That's usually on the order of several weeks to a couple months that patients experience that wonderful outcome. And then this is something that is really pleasing to know, is that 50% of patients will experience what's called a cytogenetic response, or a change in the right direction where the deletion 5q is no longer found. So that's such a nice thing to know, that the disease is actually changing for the good with this drug. Now, the side effects, as mentioned, is potentially lowering the other blood counts. Sometimes that is not immediate, and so it's important to get blood counts done regularly. Changes to the dose of lenalidomide can be made so that the other blood counts are not affected. So whether it's lowering the dose or changing the patient, not taking it every day, but sometimes we do like a 1 week break here and there every 3 weeks. Um, I've had patients have a low-grade nausea, but often not to the point where they're vomiting, and we can do things to get around that, such as taking an anti-nausea pill. And then the other side effects potentially present are fatigue and itching, but typically a drug that's tends to be a smooth one to take at home. And then next, I wanted to talk a little more in detail about a drug called luspatercept that was recently approved just a couple years ago now. And as mentioned earlier in the talk, there's a lot of different subtypes of MDS diagnosed by the pathologist. And so luspatercept was approved specifically for MDS with ring sideroblasts. Um, and and the reason for that is, in the clinical trial that studied luspatercept's effect, this subtype was the subtype that had the greatest benefit. And so that led to the FDA's approval for specifically that type. So what luspatercept is it's called a erythroid maturation agent, where it's thought that giving luspatercept prompts better maturation or proper development of the red blood cells in the bone marrow. This is taken from the company's website that developed luspatercept, where the specific pathway that's affected. Um, it's thought that the SMAD2 is damaging to proper red blood cell maturation, and so luspatercept helps to block that signaling and lead to better red blood cells. Um, and so, similar to EPO agents, um, it's thought that, or not thought, but proven that the lower the amount of EPO level in already existing in the patient, the better they will do with luspatercept, or the better chance that they will actually benefit. So I bring that up because that's the actual indication for which we give luspatercept, where either the patient has already been on an ESA or EPO and they did not get a benefit, or they had a very high EPO level going in above 500. And so we just jump right to luspatercept. Luspatercept, just like EPO, is given under the skin as an injection subcutaneously. One nice benefit is the dosing is every 3 weeks, so a little bit less clinic visits required. Um, and then in that clinical trial that led to its approval, they found that about 40% of patients no longer required transfusions at the 6-month mark. And the side effects, again, it tends to be quite mild. I've had a few patients go through this with no side effects, and then of the ones that did, were pretty similar to this profile that was reported in the clinical trial. So low back pain is probably the most common one that I've encountered, and then a low rate of fatigue, nausea, diarrhea, and then dizziness was also reported. So I wanted to give a quick word on if there is more than just anemia present. So if a patient has both anemia and thrombocytopenia or low platelet count, neutropenia or low neutrophil white blood cell count, or perhaps more ominously, they have a rising bone marrow blast percentage, then you're going to consider more than just anemia modifying treatments. So more than EPO, more than luspatercept. And what we're thinking about is potentially disease modifying treatments with hypomethylating agents. Sometimes this is referred to as like a low intensity chemo. Um, but not chemo in the traditional intensive sense. And so I'll talk a little bit more about these two drugs, azacitidine and decitabine. And these two drugs can be continued until the patient no longer benefits from it. So you continue as long as the disease seems to be under control. And then if no response or no favorable change is seen, then a clinical trial should be considered if it's available, or potentially even a bone marrow transplant if the patient's at a good age and good health status for it. I won't talk too much about this because this is kind of a whole separate talk on its own. But there's a subset of patients with what's called hypoplastic MDS, where it's thought that there's an immune mediated damage to their bone marrow precursors, where the bone marrow precursors are actually being destructed by their immune cells. And so giving suppressive agents that actually calm the immune system is a better approach. And so that again should be considered for patients with more than anemia and hypoplastic MDS. So I'm just going to spend the remainder of the time talking about these hypomethylating agents, or HMA drugs. As mentioned, there are two different types, azacitidine and decitabine. They're available as IV for both, or subcutaneous. And then more recently, decitabine in the oral form was approved. So that's really exciting that patients can do that from home. Just like a lot of our agents, we worry about the blood counts potentially getting worse, and that's much more pronounced with hypomethylating agents. I stress this a lot to patients in the clinic, that the blood counts can actually get much worse than they initially were, and that can result in even more transfusions being needed. I emphasize this because it almost appears that we're making things even worse than when we started. But what's thought is we're clearing out the MDS affected blood cells and the normal blood cells with that. But if you clear out the MDS affected cells, it potentially gives more room for normal blood cell generation. But that takes time. For the majority of patients, that takes 4 to 6 months to see that actual change in bone marrow production. And another thing that's a bit tough for patients with the traditional IV or subcutaneous form of the drugs is that they have to come in often. So azacitidine is given 7 days in a row, and then you get 3 weeks off and come in again in 28 days. And then decitabine is given every 28 days as well for days 1 through 5, and then remainder is a break. The good news for both drugs is that they're both fairly quick to administer, about 10 minutes for most places, and then you're done. Side effects, again, aren't too bad for majority of patients. Nausea can occur, so we encourage most centers to give an anti-nausea infusion or pill before the drug is given. Constipation tends to be the most common GI effect, but I've had a minority of patients have diarrhea too. And so you can give drugs to help in either direction. And then again, just want to really stress that worsened blood counts are expected, especially in the beginning. But what we hope is as patients get more and more treatment, by month 3, month 4, we hope to see an improvement and a decrease of transfusions. I included this graph from the AZA 001 trial that led to azacitidine's approval. And similar to a lot of our graphs, we measure time on the horizontal, this is in months now, and then proportion of patients alive on the Y or vertical axis. So azacitidine shown in this blue line on the top, and then conventional care on the bottom. And at that time, there really wasn't a whole lot available. So those were just simply things like blood transfusions or a different low intensity chemo that we knew didn't work too well. And so the treatment of azacitidine on the blue line led to a higher proportion of patients living. So if we draw again that 50% bar out here, we see that it falls down to about 24 months where half of patients were alive for 24 months. So meaning half of patients did better, half of patients did worse. Whereas compared to conventional care, again, drawing that 50% line, 50% of patients were alive, were about at the 15-month mark. So really azacitidine potentially makes people live longer, and also leads to a better quality of life where their blood counts are better and their transfusion need is less. Okay, so that's azacitidine and decitabine. And I wanted to give you a couple examples of patients from my own clinic, where on this left side is a patient who actually did better with HMA, or azacitidine specifically for this patient. And so his white blood cell count is shown here. And what I want to mention is this up and down nature that occurs with each cycle. So his white blood cell count was not too bad to begin with. The green and the blue are the brackets of the normal range. And so you're supposed to be between the green and blue. He's shown in purple. And so you can see he fluctuated quite a deal with each treatment, but the white blood cell was really not his biggest issue. Perhaps his biggest issue was his hemoglobin. So this was shown for all the time he was at UCSD, but I know he started treatment around here. And his hemoglobin was lousy when we started. It was 8. And as expected, he got even worse, where he went down to 6 when we started, and we had to support him with more transfusions than before. But as you can see, as time went on, from about November of 2019, gradually till about January, we started to see the light at the end of the tunnel, and his hemoglobin went up from that 6-8 range to 10 to 12. And now he's been in this 11-12 range since then. And what I like the most about this is we're no longer having these big fluctuations. He's in a fairly stable range since then and has not needed a transfusion since. His platelets have been like his white cells and a little bit frustrating for both of us, where he continues to fluctuate. So we started treatment again about here, where he had been stable in a platelet range of about 100 and he started to drift down towards 50. We started treatment and unexpected, he went from 50 to lower. And that was very frightening, I remember, for the patient. He went down to about 10 to 20. But once he got treatment, he actually had these high points with each cycle where he goes up into the 100, even 200. Frustrating thing though is he still has a low point each time. But what's heartening to see is the low point improves. So his low point at one point was about 20, 30. Then the low point became about 50 and so forth. So that's what I consider to be a good change overall. This is an example of a patient who was considered to be an HMA non-responder or just didn't have any favorable response. So white blood cell was not his issue. And what I just want to show here is there were a lot of mini fluctuations with each cycle. His hemoglobin when we started was in this about 8 range. And as mentioned, we started and it got a little bit worse. But really, we didn't see what we experienced with the last patient, where his hemoglobin just stayed in this little range of 8 to 9, 8 to 10, which was really just transfusions. But we didn't see this overall arc of improvement. And then, worst of all, was his platelet count. At the start, he was less than 50, often 30, 20. But with treatment, his platelet count just really got worse over time. I don't think it was really the HMA drug that made it worse, but the disease just got worse despite it. So where he was maybe 20, 30 at the start, he really started being more in the 5 to 10 range afterwards. So after about 6 months of treatment, we abandoned the drug. So I just wanted to contrast two examples of good and bad. And that's the end of my talk, where you have a pretty good preview of all the different types of MDS, how we stage it, and then all the different treatments. And I just wanted to give a quick shout out to the AAMDS for all these nice invitations. I really enjoy doing this. And then a lot of the clinical and research people I work with at UCSD. And with that, I'll turn it over to the facilitators in case there's any questions.
Hi, thank you so much, Dr. Tanaka. We do have a lot of questions
Oh,
lined up
okay.
for you. Yay. So what we'll do is we'll just start going through them. So, okay, your first question is, a patient has a low risk MDS since 2011 and started on Reblozyl in April of 2020.
Mhm.
Do you have any thoughts on the difference between starting Reblozyl as someone who's newly diagnosed with MDS or someone who's been diagnosed with MDS for a long time, like as in the example with this patient?
Mm.
This patient did want me to note that they have reduced their transfusion burden from once a week to once every 4 weeks.
Got it. Yeah. So Reblozyl is the trade name, and then so the generic name I just want to point out is luspatercept. So that was the drug that was recently approved. And so I'm really happy to hear that the transfusion need has reduced from every 4 weeks to every 1 week. That's not only an improvement from a quality of life standpoint, but getting many transfusions can lead to iron overload over time, and that we know is associated with potential organ damage and reduce survival. So I think that is a win in that sense. Um, as far as going into it, I think the what we use for clinical trials is really strict. When I said only about 40% of patients became transfusion free, that's because we have these really strict criteria that say less than 2 units over 8 weeks at the 6-month mark. But in reality, most patients don't fit that, but they're still overall benefiting. So if your transfusion need is lower since when you started, I think it sounds like it's the way to go. Going into it, I wonder where your EPO level was. And so that's one little nuance to maybe bring up with your doc. I'm sure there was a reason going into it why they chose luspatercept over EPO.
Thank you so much, Dr. Tanaka. Our next question comes from a patient who says, for patients with familial platelet disorders, platelet function can be deficient in addition to the deficiency in quantity. How is that factored into the risk categories, or is it?
Yeah, no, that's a very advanced question. It's very difficult to quantify a qualitative defect, as you mentioned, and that's not at all incorporated into our risk categories. So the risk categories really are just based on quantity, but we know it doesn't capture how these mutations affect the quality. We know on a research basis, those blood cells are affected. And so the only way to really affect quality is potentially with disease modifying treatments like hypomethylating agents or even a stem cell transplant. But that's a very astute insight that that is missing from our staging criteria.
Thank you so much. Are there any treatments for chromosomal abnormality trisomy 8?
Hmm.
Is trisomy 8 considered an intermediate risk factor? And if so, what really is considered the difference between intermediate and lower risk MDS?
Yeah, that's also a very nuanced question. And intermediate, yeah, exactly. So intermediate risk cytogenetics is different from intermediate risk as a whole. So when we calculate the IPSSR score, we calculate what is the cytogenetic risk. And trisomy 8 is exactly an intermediate risk score. And so that would give you, I believe, 2 points on the IPSSR, but then you have to add all the other points you might get from your blood count levels and your bone marrow blast level. And so that gives you your overall IPSSR score, which can vary. As far as targeted treatments, there's nothing specifically targeting trisomy 8 at this time. There are different targeted therapies that are in development, like neoantigen specific T cell therapies are in the works. There's also vaccine trials. And I bring that up because trisomy 8 is actually one pathophysiologically that's a little bit interesting because we know there's WT1 that's on chromosome 8 that's been associated with that, but just nothing approved yet. So it'd have to be on a clinical trial basis.
Thank you so much. Are there age-corrected risk or survival charts for patients who express MDS at a younger age versus those who express at an older age?
Yeah, that's a great question. The IPSSR actually, there is a way to age adjust where if you're above 70, that adds to your score or adds to your risk. And if you're below 70, it's thought that decreases your risk. That being said, if you're younger and you've got advanced bone marrow failure and or an increase in blasts, I would still say that the score should be taken seriously if it's a higher risk score, and considering bone marrow transplant should be considered. So it might not mean you need to do it urgently, but that conversation needs to happen early since bone marrow transplant takes several months to plan and coordinate.
Thank you, Dr. Tanaka. Is a low reticulocyte count in MDS the same as hypoplastic MDS?
Oh yeah, that's a great question. Reticulocytes are used. We often use it when we look at anemia to know how productive is the bone marrow, and it helps us categorize what type of anemia it is. But it does not refer to the actual productivity of the whole bone marrow. It's only of the anemia or the red blood cells. So hypoplastic MDS is a measurement of the entire bone marrow cellularity. So that's the white cells, the red cells, and the platelets.
Thank you. Um, are there any new treatments for TET2 mutations
Hmm.
that you're aware?
Yeah, great question there too. TET2 is thought to be potentially the most common mutation found in MDS, and also very commonly found in something called clonal hematopoiesis, which is potentially a precursor to MDS. But nothing targeting TET2 in particular right now. The prognosis or the prognostic risk of TET2 is even debatable. In a lot of studies, it's thought to be a neutral mutation, but definitely a gene of interest since it's so common.
Thank you so much, Dr. Tanaka. Our next question comes from a patient who's inquiring if should a patient postpone hypomethylating agent therapy for a low risk patient, knowing that failure with these treatments after a time means a short survival profile?
Yeah, that's a very nuanced debate to have. It's really tough. One of the things I dislike the most about HMAs is that their overall improvement is about at the 50% range. And so, going into it, it's not great odds. And what's really tough is we still don't have a way to predict who's going to be in the 50% good camp or the 50% bad camp. But that being said, if you're having advanced bone marrow failure or worsening of your blood counts, it might be the only option. And so I do advocate for trying it, especially if the complications are starting to pick up of having low blood counts. Um, and you really don't want to be in trouble with, becoming transfusion dependent, having a major bleeding event. And the reason why I advocate for trying it is because fortunately the side effects are, fairly mild for the most part. It's really that transfusion burden that can pick up.
Thank you. Our next question comes from a patient who is 76 and has multi-lineage dysplasia with ring sideroblasts at 15.5%, as well as isolated trisomy 19 and a pathogenic mutation in SRSF2.
Mm.
They do have a prior history of radiation for breast cancer, but they're doing really well, and their platelet counts have changed. They're at 75. Should they continue? Do you believe that it would be a good watch and wait, or do you have any recommendations for the?
Yeah, it sounds like that's a phenomenal recap of the disease. It sounds like there are a lot of features that do make me worried that one day this will require trying treatment. But it doesn't sound like there's anything pressing based on what I know. But one thing I do wonder about is the amount of bone marrow blasts. So if those are starting to, grow, then treatment should not be delayed too long, especially since once you cross over to the acute myeloid leukemia category, that becomes more difficult to control. And so you kind of want to, prevent that ultimate progression.
Thank you, Dr. Tanaka. We have a question from a patient who wants to know if having the gene SF3B1 makes luspatercept more effective in treatment.
Yeah, great question. SF3B1 is the mutation associated commonly with ring sideroblast presence. So it's likely that MDS-RS is the subtype that's present, and therefore luspatercept is more likely to benefit. Um, so yeah, I would say it's better odds that a benefit will be seen.
Thank you. Our next question comes, do you have any suggestions for a patient who has platelets of 20 and red cell about 9? The patient takes prednisone and has for over a year. They avoid the weekly platelet transfusions and also has EPA injections 3 times a week. Do you have any suggestions for potential courses of treatment for this patient?
Yeah, so it sounds like, progressive bone marrow failure in a global sense is present. It's not just the anemia. And so strategies outside of just EPO injections should be considered. Before weighing all the different options, what's really important is what is the patient's age, what's the overall health status, and then based on those things, then determining if bone marrow transplant, HMAs, or other things are appropriate. Also, if there's potential hypoplastic MDS, then an immunosuppressive approach might be considered. But again, the patient's age and health status is super important to figuring out which route to go.
Thank you, Dr. Tanaka. We have a question from a patient who wants to know if it's very rare to be diagnosed with trisomy 8 in a 30-something-year-old female.
Yeah, that does sound quite rare. It sounds like of a younger age than typical. And what I wonder about is what are the other features of the bone marrow? What is the medical history? Have there been any risk factors of exposure, prior chemo, radiation, et cetera, that might have prompted this? Then I also wonder about potential familial inheritance and just making sure that no one in the family has something similar. And that's someone I would highly consider doing gene mutation testing on.
Thank you so much, Dr. Tanaka. Our next question comes from a patient who wants to know they currently have low risk MDS, and they're wondering, will there be any physical symptoms that they can point to that may indicate that their disease is changing? And if so, how often should they be seeing their treating hematologist or oncologist?
Yeah, so the general symptoms to look out for are those related to having lower blood counts. So for anemia, it's feeling more fatigued, your activity level is more limited, shortness of breath, lightheadedness. For bleeding due to low platelets, it tends to be of the mucosal surfaces, so nose bleeds, gum bleeds. Very rarely you're going to have major bleeds quickly, but again, be very careful. If you've got bleeding, you should go to an ER. And then for bacterial infections, you might notice that they become more frequent or more prolonged when you have them. And then sometimes folks present with just an overall loss of function. So they might start to lose weight without meaning to. Their overall activity level and fitness might decrease. As far as how often to see your oncologist, I will leave it to them because they know your overall status. For me, it really is considering not just the blood counts, but just overall how the patient's doing and determining how often to see them.
Thank you, Dr. Tanaka. What are the chances that low risk MDS will progress to AML?
Yeah, I would say on the whole, it's low. We know that from the IPSSR. Fortunately, there's a lot of good data to support that. That being said, there have been patients who present in a low risk manner, and much down the line, they pick up an additional mutation that then triggers the leukemic transformation. And that's what's frustrating. We don't have a way to predict if that event happens, but on the whole, it's very rare.
Thank you. Are there any specific diet or supplements that an MDS patient should follow in order to maximize their overall health?
Yeah, great question. One I get very often in the clinic. There's unfortunately no diets that have been proven to change the course of the disease. But what I say is just try to have a healthy lifestyle going in, just so you don't augment other disorders that could make having MDS worse. So you want to make sure that your other medical illnesses stay in check, like heart disease, diabetes, and so forth. Some exceptions is making sure that the diet is not too strict. Sometimes I've got patients on strict diets, vegan, vegetarian, nothing against it, but making sure you get all of your proper vitamins and minerals from that. Or if you've got any sort of GI disorders, malabsorption, gut disorders, prior bariatric surgery, making sure that's not impeding your ability to get all the balanced nutrition you need. But otherwise, nothing specifically for MDS to change it. Mhm.
Thank you, Dr. Tanaka. Our next question comes from a patient who is wondering how common it is to have a Y mutation in MDS.
Oh, yeah, great question. Y mutation is seen, and what's a little difficult, it's not specific to MDS. It can happen with age. And so we don't lean on it too heavily to say this is MDS specific. It can occur outside of MDS.
Thank you so much. Our next question comes from a patient, and it ties into Dr. Paquette's presentation this morning. But to reiterate, do you have any recommendations for MDS patients specific to COVID vaccination? Is there a preferred vaccine in your opinion?
Oh, yeah. So I don't have a preferred one to recommend out of the ones that are approved. In a general sense, I recommend patients receive the vaccine. There's been multiple studies now showing that patients with high risk hematologic malignancies do worse with COVID infections, higher mortality rates. And so, in that general sense, I recommend getting the vaccine. But I'll give the common out, which is check with your doctor if there are any specific concerns to just you outside of that general recommendation.
It- Thank you so much, Dr. Tanaka. Do you have any recommendations for exercise regimes that you might recommend? Are there any particular exercises that are most appropriate for lower risk MDS patients?
Oh yeah, I like that question a lot. A lot of it's maintaining your fitness, and in patients, often muscle tone and bulk is ignored. It's not just about cardio. As we age, lots of muscle tone is lost in the proximal muscles, like the thighs. So making sure you do things that maintain your activities of daily living, and what the one thing to caution with if you've got a low platelet count is making sure to avoid anything with trauma risk. So don't lift objects above your head or do it with close supervision. And then for anemia, if that's present, just making sure if you do activity that makes you change your body position, not letting that exacerbate the symptoms that you have. But I think that's a great question. I've got a lot of patients with low risk MDS that bike 5, 6 miles a day. And so trying to maintain that is great.
Thank you so much, Dr. Tanaka. We have a question from a patient who wants to know, is hemochromatosis considered a comorbidity to MDS?
Oh yeah, that's a great question. Hemochromatosis is a word that's kind of like a general word for iron overload. And so you can have primary hemochromatosis or secondary hemochromatosis. Primary means it was hereditary or a condition you were born with, where you received a gene mutation from your parents, and it led to the iron overload state. Secondary is when it's secondary to receiving multiple transfusions for another disorder, such as MDS. So it can indeed be a comorbid condition related to the MDS transfusions.
Thank you, Dr. Tanaka. Our last question comes from actually several patients who are inquiring about the risk benefit for going to transplant as a low risk MDS patient. Are there situations in which you would recommend that for your patients?
Yeah, indeed. There are situations, it's not as common compared to higher risk MDS. I'm not surprised this is a common question. And Unfortunately, the options for treatment are very limited for MDS once the ones I mentioned have been exhausted. So, outside of the anemia supporting drugs, potentially platelet supporting drugs such as L-trombopag, and then outside of the HMAs, we really are just stuck with clinical trials and bone marrow transplant. And so if those things have been exhausted, the patient is transfusion dependent and the complications from that are rising, then I do think bone marrow transplant is definitely an option to be explored as long as the patient's a good age and there's a good donor out there.
Thank you ever so much. I did miss one question. My apologies. We have
Oh,
one last
yeah.
question before we close, which is, is there any data yet on the COVID vaccine and an increase in changing stages of MDS? Would getting the COVID vaccine somehow make your MDS worse?
Oh, got it. I I don't know of data that exists. I don't imagine, just thinking of it from a mechanistic standpoint, that it would make your MDS worse, because the vaccines affect your adaptive immune system, where you're training your immune cells to create memory against certain pathogens. And so those involve your lymphocytes, which are not typically affected in MDS. Um, so I don't imagine that being a possibility, but I have not seen data to say it either direction yet.
Thank you so much, Dr. Tanaka, for your time and attention to all of these questions. If we were unable to get to your question today, we apologize, but you can send your question to us at help, HELP, at aamds.org. The slides and the recording of this presentation will be available after the conference is over with sometime next week. So give us 3 to 5 business days. The recording should actually be available almost immediately, but the slides, if you'd like them, please do send an email to help, HELP, at AAMDSIF. I would like to share our closing slide now, if I may. I want to just remind everyone who's with us today that at the end of today's today's conference, we will be having our virtual support groups, which are free and available. They're accessible on Zoom, and the link is on your landing page in your attendee hub. Those start at 4 p.m. Eastern, 1 p.m. Pacific time. I also want to remind you that the March for Marrow California kicks off in a couple of weeks. And in order to march for Marrow, you'll need to sign up at marchformarrow.org, or you can take the time now that we are wrapping up this session and go visit our exhibit hall, including all of our wonderful exhibitors, friends, and sponsors. Those folks will be available to you now, and our next session begins in about 22 minutes. So on behalf of myself at the foundation, I want to thank Dr. Tanaka again for her time and